Good afternoon, everyone. So today I'll be talking to you a bit about uncertainty analysis in economic evaluation. So we're going to cover what uncertainty is, some of the different types of uncertainty that exist, and then look at a case study that we did here in economic evaluation of maternal pertussis immunisation in Thailand to look at some of the techniques that you can use to address the different types of uncertainty. So maybe just to give you a bit of an overview in terms of what uncertainty is, there's different definitions in the literature, everything from something that is uncertain to unknown, not completely deterministic, but in general there are three main categories of what's considered under uncertainty. So the first one is natural randomness or variability in a system. So you can think of this a bit like tossing a coin or rolling the dice. If you carry that activity out multiple times, it will let you see whether the probabilities are even, whether it's potentially a weighted die, but you can't ever get to the stage where if you then flip a coin, you'll be able to tell with certainty whether it's a heads or a tails. You'll be able to better characterize the probabilities, but there's always going to be some inherent natural randomness or variation. So we call that stochastic or aleatory uncertainty. There's another type of uncertainty as well, which stems from imperfect knowledge of a system. So there is a true value, and in theory you can get to that true value, but because of our measurement techniques, because of limited knowledge about the system, we don't actually know what that true value is. So that can be reduced by better data. So that can be better techniques for measurement, but it also comes in terms of issues like generalizability and applicability. So are you using data from a different setting, from a different country? Potentially you're looking at coverage levels of one vaccine and assuming it's going to be the same in another vaccine. So that's the second type or category of uncertainty that you can think about. And then the final one, which we often don't think about as much in economic evaluation, is sometimes called ambiguity. So it's about stakeholder interpretation. So normally when we're doing an economic evaluation in healthcare, it's intended to inform policy, it's intended to support decision making. And so obviously there's a certain uncertainty in terms of how those decision makers, those different stakeholders are going to interpret the results of your analysis and the value judgments that they're going to apply in terms of how they use those outputs and use it to come to a recommendation, and then how what you have modelled is actually implemented after that decision has been taken. And then maybe just to take a step back and to consider, okay, well, why is it actually important that we do undertake an uncertainty analysis? Why is it important to consider uncertainty in economic evaluations for healthcare? So if you think about it, if you think about all of the different sources of uncertainty that you have from your model, overall, in total, that represents the probability of making a wrong decision. So for example, if you're looking at, you currently have drug A in your health system and you're thinking about whether it's actually, there's good evidence that you should replace it with new drug B, what's the probability that you're actually choosing the least cost-effective option if you have a cost-effectiveness model? But then also if you consider that in terms of the impact of making the wrong decision. If you choose drug B, but actually it turns out that in reality drug A is better. Is it that, you know, it's just a minor budget impact issue, or is it actually that there's a huge amount of cost and potentially lives involved in making the wrong decision? And then when you think about the probability or the uncertainty of making the wrong decision combined with the impact, that represents the decision risk. So what's the likelihood and impact of potentially making a wrong decision? And so in terms of the types of uncertainty, just in a bit more detail, that we have for economic evaluation in healthcare. So on the screen, this is a very simplified version of the process that you normally go to when you're building a model for economic evaluation. Obviously, you'll probably notice that there's a bit more of iterative loops when you actually go through the process. But overall, you have the first stage where you structure what the decision problem is. So which population are you looking at? Which interventions are you going to consider? What's the comparator and what are the outcomes of interest? You then structure the model around this. So you decide like what type of model you're going to use and what are the events, what's the clinical pathway that you're actually going to look at within that model. And then you populate the model. So you put the data in, you hopefully get some outputs from your model, those are used for policy, and then that policy is implemented. So there is a lot more reading at the end of the presentation for anyone who is interested, but these are the different types of uncertainty, just very roughly mapped against those different stages. So the first one is decision problem uncertainty. So that's, have you set up your question correctly in the first place? So for example here, if we take the comparator, there may be a specific recommendation in your clinical practice guidelines. Are you going to use that in your model? Because it may be that, yes, the clinical practice guidelines recommend one thing, but actually in practice, if you go down to the clinics, that's not what's happening. And so if you model with those two different comparators, they're both going to give different results. So that's the decision problem uncertainty. Have you chosen an appropriate population intervention comparator and outcome? So the next one is in terms of structuring the model. So there's been a lot of work around this in the last 10, 15 years or so. So probably the reference from 2018 that's on the screen, I think that's the most updated one in terms of clearly outlining the different types of structural uncertainty. But the first one is in terms of the conceptual model. So Nan showed you earlier the example of a decision tree. So for example, if you're using a decision tree model, have you set up the branches in a way that is actually representative of the clinical progression of the disease? Have you represented what the patient pathway actually looks like, for example? Another one is in terms of the structural choices. So this relates to the functions that actually connect those different data points that you have in the model and then come to the outcome. So an example of this that's often a big source of uncertainty in economic evaluation is extrapolation. So you can think about an example where you're modeling an intervention for alcohol addiction, for example. You have data from clinical trials about rates of abstinence, but only up to 2 years, and you want to take a longer view in your model. How are you going to model those outcomes? If you have data points over time, are you just going to smooth that? Are you going to consider that there's, that's then going to be representative of the future changes in abstinence with the intervention? And then the last one is in terms of the platform. So by that we mean the type of model and the software that you use to run that model as well. So Nan covered it earlier, but that's when you make the choice between a decision tree, a Markov model, and an issue that we often have in terms of HTA as well is the balance between being pragmatic. Static models are often a lot simpler versus when you really do actually need to use a dynamic model because there is change in terms of transmission that you're going to need to model. And then the next step of populating the model. So there are two considerations that you have there. The first one, methodological uncertainty. This, you can think of it a bit in terms of the artistic license that you have as a modeler. So this comes to choices around time horizon. It comes down to choices around discount rates. There is no true value of that. It's inherently a value judgment. But that does introduce uncertainty. Different modelers have different choices, and that's going to change what the output of the model is. And then the one which I think most people feel most confident with or think of most when we talk about uncertainty is what we normally call parameter uncertainty. So that's uncertainty in the data points that you're putting in. So it might be stochastic uncertainty. So that's covering like the random variability, tossing a coin, throwing a dice type of uncertainty. There's the direct epistemic uncertainty. So that's where there is a true value. You're just not sure, for example, whether you've measured it correctly, where there's kind of uncertainty in terms of what that true value is. And then there's also indirect epistemic uncertainty. So that's coming back to this question about quality of the data. So internal bias, was the study conducted well? Was it measuring what it actually said it was measuring? But also external bias, which is an issue around generalizability and applicability. That's the question around, are you using data from a different country, from a different program, from a different setting, and to what extent is it actually likely to be representative of the true value in your setting of interest? And then we discussed this a bit earlier, there's some uncertainty in terms of how those outputs are actually used for policy, what the interpretation of the outputs is, the different decision variables in terms of the criteria and thresholds that are used to come to a decision. And then in some of the literature, they also talk about decision maker, policy maker, random variability as well. And then we have the uncertainty in terms of how it's implemented. So this may be, for example, are the clinicians actually going to follow the recommendation that is made? It could be in terms of the quality of care that's provided. Maybe that's not reflective of what actually happened in the model. But it can also be issues such as if you have a new intervention, you've modeled it against the comparator, it's very cost effective, but it also has a very high budget impact. In that instance, if you've got a fixed budget and you're introducing this new intervention, you're not just displacing your comparator. To have enough money to actually fund the intervention, you're going to need to cut the budget from other areas as well. There is a possibility that the budget is cut from more cost-effective interventions than the intervention that you have just included. And that's also part of the implementation uncertainty. You don't know how that extra budget is going to be made unless it's a healthcare system which works a bit like New Zealand, where they do. But in lots of healthcare systems of the world, that's not how decisions are taken, and there's uncertainty in that respect as well. So now I'm going to walk you through one of the studies that we did here at HITAP, just to explain to you and illustrate some of the techniques that you can use for uncertainty analysis when you're doing your economic evaluation. So just a bit of background in terms of the problem that we had. So because there's very good infant immunisation schedule in Thailand, there's actually very low rates of pertussis, or we think there are from surveillance data. Pertussis is a bit notorious in terms of being able to get good surveillance data. But the highest rates of pertussis in Thailand are actually in the first 6 months of life, and often in the first 3 months of age. So it's before a baby receives its first DTP1 vaccination. And this is the case in lots of countries. And so WHO's position is that to protect those infants, so in the first couple of months of life, the best protection for them is for the mother to be vaccinated during pregnancy against pertussis. And so it's recommended by WHO that in countries or settings where they have high infant morbidity or mortality from pertussis to consider this as a strategy. So that was the rationale in Thailand why the National List of Essential Vaccines actually wanted an economic evaluation of maternal pertussis immunisation, should it be introduced into the Thai National Immunisation Schedule. And I'm now just going to outline a couple of principles which I think may be very helpful as you're thinking about uncertainty analysis, because you can go as far as you want, you can get very detailed, you can go down all of the rabbit holes with uncertainty analysis, but essentially, if you find that an assumption is important, look into it in more detail, elaborate the model. If an assumption is unimportant, simplify the model. If you're looking, you run an uncertainty analysis and a certain parameter, a certain element doesn't seem to be having a huge impact on the model, okay, move on, don't worry about it too much. But if you find that there is one which is having a very important impact on your result, then you probably want to look into it a bit further and run additional analysis. So those are the principles that I'm going to try and demonstrate in terms of the study that we did. So if we go back to this kind of overview of the different steps of elaborating the model and the uncertainty that there is, if we think about the decision problem uncertainty that we had in this case, so some of the questions that we had when we were structuring the model, so we're going to look at the outcomes in infants, but until which age should we model? Do we model until they receive their first dose of vaccine? Do we assume that there are actually some infants who either are not vaccinated on time, or they receive the vaccine but they have a very poor immune response? They are still susceptible to pertussis. And the second question that we had in terms of population was, do we include pregnant women or not? Because when we were looking at other economic evaluations that had been done on this question in other countries, sometimes they include pregnant women, sometimes they don't. And so that was another question that we had. Then in terms of the intervention, So we're looking at maternal pertussis immunisation, but should we also model cocooning? That's another strategy that's used, and that's where all, definitely the mother, but normally the father too, and anyone who's in close contact with the baby is actually vaccinated against pertussis. The idea is to stop transmission to the baby. And then there's also a question around, should we consider maternal pertussis immunisation every single time a woman gets pregnant? So if she has 7 children, she gets vaccinated 7 times against pertussis. Or should we look at immunising her for the first pregnancy only? So there's a bit of conflicting data around how long that immunity actually lasts in adults. For the comparator and outcome, this is there's quite good guidance in the Thai HTA guidelines. So we had less uncertainty in that. We followed what the guidelines told us. And then in terms of how you normally address this type of uncertainty, the current recommendation, what's considered best practice at the moment, is that you justify the selection. No one can necessarily say 100% whether you have set up the decision question in the correct way. What's important is that you explain how you have done it and why you have done it. So on the screen, I'm not going to go through it, but essentially what we did is we put together a table with those different elements of population, intervention, comparator, and outcome. We justified what, for example, our population was, and then gave the different evidence sources and the different quotations from the literature to explain why and justify why we had made that recommendation. And that's important because when someone's then looking at your model and they're questioning why did you set up the model in that way, they can challenge it, and it's transparent, and people know how to interpret your results. In terms of the next one of structuring the model, so I'm going to go through these 3 different elements. So the first structural uncertainty we had was in terms of the conceptual model, so in terms of the clinical pathway. And this remained even after we had done a literature review in terms of pertussis itself, but also how other economic evaluation studies had set up their model, the different pathways that they had used. And we also had a stakeholder meeting with clinicians, with different experts, academics in Thailand, and there wasn't a consensus coming out of that meeting either. So in this case, what we did was we actually built 2 different models. So one of them, the model was more of a after hospitalisation, is there ICU admission or not? And then looking at the different chronic outcomes after ICU admission and assuming that only happens in the severe cases that are admitted to ICU. Whereas otherwise it was they're hospitalised, and then taking more of a disease-specific approach to that, and then looking at the different outcomes that come from the different presentations. And so when we ran the model comparison, again, you can read a bit more if you're interested in terms of how there are some very sophisticated quantitative techniques to compare different model structures. In this case, both of our models gave very similar results. So we didn't go to that extra effort of quantifying the difference and running the probability and fitting a distribution to it, because the 2 models gave very similar results. That was obviously not driving the majority of uncertainty in our model, and so we just stuck with one base model and just provided the results from the other model for comparison. This is just an example. We actually had many examples of this in terms of structural choices. So if you remember, this is in terms of the functions, how you actually link up those different data points to come to your output. So one of the issues we had was in terms of the protection. So we did, in the end, decide to include pregnant women. But in terms of the vaccine effectiveness in adults, the data that we found was from a meta-analysis. And if you look at where the red box is on the screen, so this is like the vaccine effectiveness at 1 year, 2 years after vaccination, 3 years after vaccination, you'll notice that for some reason it appears that 4 years after vaccination people actually have a better protection than 3 years after vaccination. Unlikely to be the case, probably because of the methods that were used for the meta-analysis and some of the limitations in the data. But then there was a question for us in terms of, well, are we just going to plug those raw values into our model? Are we going to try and smooth out the points in any way? And in this case, again, going back to what's pragmatic, what's actually going to influence the outcomes. When we ran our initial analysis, just using the raw data, the maternal outcomes had a very, very, very small impact on the result. Essentially, all of our health impact outcomes were being driven by the benefit of vaccination in infants. So in this case, we didn't do any further analysis. We didn't look at any sophisticated functions. It's got a very minimal impact on the result. We just used that data straight from the meta-analysis. And then the third question that we had in terms of structural uncertainty, in the literature, there are lots of economic evaluation models that use a decision tree, sometimes with a Markov model at the end of the branches. I believe Nan has talked to you about that. And the rationale for doing that is that even though it's an infectious disease, you assume that an infant doesn't really have many contacts. An infant, if they're going to get pertussis, normally it's from the mother. And an infant is unlikely to be passing on pertussis to anyone. They probably got it from the people who they could pass it on to. And so that's why it's often considered okay to use a decision tree in this instance, even though if you're modelling pertussis in children, in adolescents, in adults, you would want a dynamic model and not a static model. But when we were reviewing the literature, there's a bit of disagreement in terms of whether there is benefit of that extra effort of building a dynamic model. And so because for us it's a lot more practical, it's a lot simpler to build a decision tree model, we chose to use a decision tree model, and we then considered qualitatively at the end, potentially the decision tree may overestimate the cost effectiveness. In our instance, the result was very, very not cost effective, so we thought that the implications of us using a decision tree model were very, very minor. And then in terms of methodological uncertainty, so this is your artistic license that you have as a modeler. So the normal recommendation, and this is pretty consistent in the health technology assessment literature, adhere to a methods guide. So in Thailand, we do have a methods guide for how you conduct health technology assessment and economic evaluations. So here, for example, it does specify that the discount rate for both costs and outcomes should be set at 3%, and then you run a sensitivity analysis at 0 and 6%. So that is what we used. In settings, I'll show you there is a link. There is guidance in the HTA manual for India, but there are also global resources as well that you can use if you're working in a setting where there isn't necessarily this guidance. But the purpose of this is there is no true value, but you want to make sure that people aren't choosing which values they use to get a certain output. And you want to ensure consistency and comparability in all of the different decision problems that are addressed. So it standardizes how an economic evaluation will make these methodological choices. And then parameter uncertainty for the next part. So there are a number of techniques that you can use for parameter uncertainty. The first one is deterministic sensitivity analysis. This is also called one-way sensitivity analysis. You can also do multi-way sensitivity analysis, but in its very simple form, essentially you take one of your parameters at a time, you set it to what you think of as the upper bound, so what's the most likely higher value that it could be. Importantly, look at whether it has any impact on the result, and then you set it to the lower bound, or what you think is the most likely realistic lower point that it could be, and then again look at the range there. So what you see on the screen is in our analysis the 5 parameters that had the greatest impact on results. Note that normally for the methodological uncertainty analysis as well, you can put in these factors. So for example, discount rate is circled here. You can put them in the deterministic sensitivity analysis. What's important to note here is that for us, even though these are the top 5 most parameters which have the greatest influence on results, the only one which actually changed whether or not the intervention was cost effective was pertussis incidence. So to a certain extent, we ignored a bit the other parameters because even varying them, unlikely to change whether or not the intervention was cost effective. And then just to show you quickly in terms of how this is done in practice. So firstly, you calculate the upper and lower bound for each parameter. So what do you think is a sensible range in terms of where this parameter could be? So often if you're taking data from a study with a 95% confidence interval, normally you would use this to set what your upper and lower bounds are. And again, you can calculate this if there's standard deviation given. Another way of doing it, if you don't have that kind of spread or deviation given to you in the results, is to take a certain percentage. So in this case, we did plus minus 20%. Some people argue that maybe you should be a bit more conservative and use like plus minus 100% of the value, but you kind of set some arbitrary way of setting what your upper and lower bound is going to be. Another way of doing it is kind of almost a bit like a scenario analysis. So you use an alternative data source. So this is what we actually did for pertussis incidents. So we were a bit concerned about the quality of the data because even though there is national surveillance data for pertussis incidents in Thailand, everywhere in the world, it's known that it's very, very difficult to estimate what the actual pertussis incidence is, because by the time that the symptoms have been there long enough, it's very difficult to actually take a lab culture and identify whether it is pertussis or not. So we used a couple of alternative data sources. So we used one from Brazil, which is what we used for the upper bound here, and this is a country which, even though it doesn't seem like it's similar to Thailand in terms of their immunisation schedule, the type of vaccine that is delivered, and also a couple of other factors as well in terms of how their health system is set up, it seems like it was a sensible option to use instead of, because the pertussis incidence data, that the confidence interval was actually very tight because it's nationwide data. It would give the impression that you actually have a lot more certainty than you do. So they were, in this case, because there was more issues around the quality of the data and potential bias in terms of how the data is collected, that we decided to use alternative data sources to set the upper and lower bound. And then, as I discussed, you run it one parameter at a time, you change it to the lower bound, rerun your whole analysis. What's the change in the output? Change that to the upper bound for that parameter, rerun the analysis. What's the change in output, and you do that for every single parameter that you have in your model. So it does take time. I'd recommend writing a macro for it. And then the second example, you've probably heard of this one as well, is probabilistic sensitivity analysis. So deterministic sensitivity analysis, you're only changing one-way deterministic sensitivity analysis. You change one parameter at a time. And you're also just looking at not necessarily the extremes, but you're looking at a feasible range. And you're not taking into account that actually, maybe you've considered, you think it's about 15, you think realistically it could be anywhere between 10 and 20. But in terms of most distributions, you'd normally think that maybe 14 or 16 is a lot more likely than getting a 10 or a 20. So probabilistic sensitivity analysis, it takes into account that spread or that distribution of the points, so that it's probably more likely that it's going to be a value closer to the mean or closer to the deterministic value that you've used, as opposed to a value which is quite far away. It also changes all of the parameters in one go. So what you do is you sample from the distribution for each of the parameters. You do that for every single parameter at the same time. So you change all of the parameters in one go, and then you run it and you look at what's the change in your output. And you do that many times. So normally if you're using a Monte Carlo analysis, you'd run about 1,000 loops is typical, but there are equations which guide you in terms of how many samples you need to take. And then you plot it, and it will look a bit like the graph that we have here. So I put this on the isoplane, so you have the health impact in terms of quality adjusted life years along the x-axis, you've got the cost on the y-axis, and then anything, so I've plotted that dotted line in the middle is the cost effectiveness threshold in Thailand. So anything below that line is cost effective, anything above the line is not cost effective. And it lets you see, like, the cross there is what we got from the deterministic analysis. So before we did any sensitivity analysis, that's the output that we got. Very not looking cost effective at all. And then each of the different points is we ran many thousands of iterations of changing all of the parameters simultaneously, sampling from their respective distributions. And it shows that, okay, occasionally you can see a couple of pink and blue dots that are in that cost-effective range, but compared to the number of dots in the not cost-effective range, the probability of it being cost-effective is very, very low with the current high cost-effectiveness threshold. And then the final type of analysis I'm just going to talk to you about here is threshold analysis. So in the first two, we were looking to see how does the output change if we vary the parameters. In a threshold analysis, you're being a bit more directive in terms of what you want the cost effectiveness to be and how much would a parameter need to change to reach that cost effectiveness. So in this example, maternal pertussis immunisation is not cost effective in Thailand. What would the price need to be of the vaccine to make it cost effective? So essentially, so you'll see here, this is the analysis that was run for vaccine price. So what does the price need to be to mean that this lower bound pinkish red bar actually is brought to that dotted line which represents the cost effectiveness threshold in Thailand? How low does the price need to be? And you might see that if you look at the AP price table in the corner, it was around 27 baht, which is about $0.50, so well, less than $1. So unlikely the manufacturer is going to bring it down to that price, but there are other situations where it might be a bit more helpful in price negotiations. But you can also use this threshold analysis not just for price. So in this example, so if you remember earlier, there was the part about if an assumption seems very important, then elaborate the model. So we found from both the deterministic and also the probabilistic sensitivity analysis, and we also ran what's called expected value of partial perfect information as well. Pertussis incidence in infants is very, very important in terms of how cost effective the intervention is. So we took a very high upper bound in terms of pertussis incidence, which was based not on empirical data, but in terms of an equation that was used in the WHO global burden of pertussis study. And we said, okay, so if this is the true incidence of pertussis in Thailand, we have data from a national hospital database in terms of how many infants are being hospitalized for pertussis each year. What would the level of underreporting in hospitals need to be for it to actually be realistic to have this very high pertussis incidence? So we ran a threshold analysis to identify what's the threshold number of hospitalizations a year. That would mean that it is still cost effective, because in our model, most of the costs are coming from hospitalization and from ICU admission. So if it turns out that, okay, there is really high pertussis incidence, but most of those cases aren't actually being hospitalized, most of them aren't serious, then it's likely that even though we have underestimated pertussis incidence, pertussis immunization is still not going to be cost effective. However, if it turns out that actually there is still a very high rate of hospitalization, then it might be that maternal pertussis immunization is cost effective. So what we do is we ran this threshold analysis to say, okay, so we'll assume that we have the WHO level of pertussis incidence, which is far higher than the surveillance data in Thailand says it is. But if we assume this, what is the lowest possible hospitalization rate, which would mean that the intervention is still cost effective? And when we calculated that, it was 0.13, which equates to about, with the number of infants in Thailand, that equates to about 327 infant hospitalizations per year. In terms of the national database, it's between 9 and 37 hospitalizations are recorded. So then, our conclusion was that the majority of underreporting is likely to be among non-hospitalized cases, but again, it's something you can take to the decision maker and say, okay, so we think that if we are underestimating pertussis incidence, you would need to assume that it's not just general pertussis incidence, but it's hospitalisation incidence. We're underreporting at a factor of about, it's actually 8 times higher than we seem to be reporting in the hospital records. So that's a way that you can help decision makers navigate, even when there is quite a high level of uncertainty in your study. And then the last part I will talk about today is in terms of the uncertainty in using the outputs for policy. So I've spoken a bit already in terms of the cost effectiveness threshold in Thailand. And so if you have, again, just to reorient you for anyone who's not used to seeing this kind of plane before, so along the bottom, that's your health impact. Going up, y-axis, that's the cost. And we normally plot, you'll normally see it looking a bit like this. So I've just shown the part where there's a positive health impact, but there's also increased cost involved. And so the blue dashed line that you see, in Thailand, there's a cost effectiveness threshold is defined. It's 160,000 Thai baht per QALY. So it's saying that the Thai government is willing to pay 160,000 Thai baht for every quality adjusted life year gained. It's not a hard and fast rule, but it helps to guide decision making. And so anything that's kind of like blue and noted as include, that is cost effective in Thailand. Anything that's pink and is in the exclude part, that's not cost effective in Thailand. So one of the questions that we had when we first ran this analysis, lots of other countries were finding that maternal pertussis immunisation is cost effective. So Canada, the UK, the US, New Zealand, I think Japan as well, they were all finding that it was actually cost effective to introduce maternal pertussis immunisation. We were finding that it's not cost effective at all. And so we were thinking, okay, is that an issue of generalizability? Because we have very different setup of, for example, the health system, or there are very different cost structures in Thailand as compared to these other countries, which are predominantly high income and might be set up in a very different way. But when we took the economic evaluation estimates for all of the different countries, we adjusted it to the same year of analysis that we were using, so using the different inflation rates, and we also adjusted it to Thai baht, so using the currency exchange as well. It turns out, and that's what's shown on the graph here, that our results, which are the green Thailand dots that you can see, they're actually smack bang in the middle of the cost effectiveness estimates from other countries. So if this is the case, we have a very similar cost effectiveness estimate. Why is it not cost effective in Thailand? And what you can see from that is it's because the cost effectiveness threshold for Thailand is a lot slower than in many high income countries. So this chart shows, so on the y-axis is the probability that each of the interventions is cost effective. So the black line kind of coming down, that's the comparator, that's the existing situation in Thailand at the moment, which is maternal immunisation with tetanus diphtheria. You then have we considered 2 different types of maternal pertussis vaccination. So the blue one is just adding acellular pertussis single shot on top of the TD vaccine that's already given. And that red line that you see kind of on the bottom, that is replacing the TD vaccine with a combination vaccine that includes TD and acellular pertussis as well. So you'll see that the pink dashed line is the Thai threshold. And the Thai threshold, that black line, it's around, I don't know, about 80% likely that not introducing maternal pertussis immunisation is the most cost-effective option. But I've just put an arrow, it's the orange arrow here, just pointing off the page. The threshold in the UK, if you, again, convert it to Thai baht and not British pounds, it's off the graph. And so you can see that actually by the time you get to the UK threshold, that black line that's saying TD only, it actually drops below 50%. And when the comparator is below 50%, that means that actually one of these, like either the blue or red lines for introducing maternal pertussis immunisation, that is the more cost-effective option. So that's to illustrate that the different decision rules that a country has in place in terms of, well, it could be the criteria, but also in terms of which cost effectiveness threshold is considered as the decision to introduce or not introduce, that can also impact as well. in terms of the decision that's finally taken and how your model outputs are going to be used. And I'll let you think, because we haven't yet. So there has actually been a decision that even though it's not cost effective for other reasons, this vaccine is going to be introduced in Thailand. But you can maybe think a bit about, in terms of implementation uncertainty, what that would be. But maybe just to close. So firstly, just to point out that there are guidelines for conducting economic evaluation in healthcare, which do include some sections on uncertainty, the types of analysis that you should use, which types of uncertainty should be addressed. So there's a link in the slides to the CHIS 2022 statement, that's just generic. But there's also the Health Technology Assessment in India, a manual that gives India-specific recommendations. And then here are some references as well. I've tried to separate them out into the certain sections, so you only need to read or review whatever is interesting for you as well. So thank you very much. I hope that was helpful, and have a productive and enjoyable rest of the workshop.